My name is Deborah Stevens. I'm a psychiatric nurse practitioner student at the University of Texas, Rio Grande Valley. The topic today will be schizophrenia. I chose case study number 3. Adult onset schizophrenia is a disabling serious mental disorder characterized by persistent delusions, hallucinations, and cognitive impairment. Schizophrenia occurs in 1% of the population internationally, with a typical onset 18 and 25 for men. Case number 3 is a 20-year-old African-American male with poor insight, judgment. He is uncooperative, presenting to the emergency department after being removed from college campus police. He has had a long history of behavioral that is odd over the last year. Spent most of his time laying in bed staring at the ceiling. He stopped seeing his friends and stopped talking to his family. His sister noted that he was mumbling quietly to himself often. He also stood on the roof of their home and waved his arm as he was conducting a symphony. He also went to the college campus. I am the Joker, and I am looking for Batman. Mr. Baker, maternal grandmother, passed away in a state psychiatric facility. The diagnosis was unknown. Studies have shown that genetic factors are linked to schizophrenia. Risk of the illness is 10% for first-degree relatives and 3% for second-degree relatives. His mother is known to have a mental illness as well. His mother abandoned the family when he was very young. Studies have shown that schizophrenia is a hereditary brain illness. A 2016 study of the major histocompatibility complex locus demonstrated that expression of complement component 4-LEA, C4A for short, was proportional to the risk of having schizophrenia. C4A in the brain had greater expression and association with schizophrenia. Diagnostic criteria for schizophrenia is 2 or more positive, negative, and cognitive symptoms, as well as negative. Disturbance with interpersonal relationships. Mr. Baker had failure to achieve expected level of academic and self-care. The above symptoms need to persist for at least 6 months. Schizoaffective, bipolar, depressive disorders need to be ruled out. There must be no attributable medical or substance abuse disorder. Mr. Baker was healthy. He had no substance abuse disorder. Onset early 20 symptoms are abrupt and insidious. Mr. Baker has positive symptoms of schizophrenia. For instance, he was removed from college campus by security for yelling out in classroom, "I'm a joker." He recently was seen mumbling to himself, stood on a home roof waving his arms conducting a symphony, felt liberated and in tune with music when on the roof. He had grandiose and romantic delusions, writing many letters to his neighbor, and there was no relationship that existed. He was internally preoccupied with auditory or visual hallucinations, according to the psychiatrist at the hospital. He refused hospital food and water and thought it was poisoned, so he had paranoia. Mr. Baker had negative symptoms of schizophrenia. For instance, he was suspended from college for lack of attendance. He withdrew from friends and family. He had a blank stare. His mood and affect were constricted. He was very guarded in the fact that he refused to go to the hospital to see a psychiatrist. He refused treatment. He was inattentive to schoolwork, his family, his friends. And he stated that he was feeling bad. It's a very vague symptom, but possible he has depression and was withdrawn. Mr. Baker showed cognitive symptoms of schizophrenia. He had stopped socializing with his friends, family, and rarely spoke. Cognitive symptoms of impairment can be subtle and severe. It includes impairment of and often precedes the onset of the positive symptoms. They include poor focus, poor insight, and poor judgment. He also had poor verbal comprehension and not understanding that he needed help for his illness. He was uncooperative at the hospital with the doctor and with his family. Prognosis for schizophrenia patients. Mr. Baker most likely has a 50% or more of repeated hospitalizations, possibly legal issues, incarcerated for minor offenses, increased suicidal attempts, poor social skills, vocational difficulties, and poor relationships resulting in poverty and homelessness. Due to his refusal or denial that he has schizophrenia. Patients diagnosed with schizophrenia are 3 times more likely to be diagnosed with alcohol or tobacco disorder than the general population. Although Mr. Baker and his family reported he had no alcohol or illicit drug use. Patient often has limited access to transportation for medical or care, which can result from poor control of disease, such as metabolic syndrome if they do take their medicine. Treatment for schizophrenia includes antipsychotic medications in the form of oral or injections, and they should be chosen selectively, such as in a first psychotic episode, partial responders, or treatment-resistant schizophrenia. For Mr. Baker, a second-generation antipsychotic would be the best, such as Zyprexa, Abilify, or Risperdal. For aggressive or violent patients, Haldol is suggested. This is a first-generational antipsychotic. Mr. Baker does not seem to be that aggressive at this time. If Mr. Baker would fail first-generation and second-generation antipsychotics, the patient could be treated with clonazepam. The purpose of this research was to assess new generation antipsychotics, Vraylar, in adult patients with negative symptoms of schizophrenia. The trial randomly assigned 461 patients with schizophrenia for 2 years with predominantly negative symptoms. The mean target dose for Vraylar was 6 milligrams per day and Risperdal 6 milligrams per day for 26 weeks. There were 230 patients on Vraylar and 231 patients on Risperdal. At 26 weeks, the group assigned to the Vraylar showed a more significant decrease in schizophrenia negative symptoms. The patients on Vraylar had a 54% decrease in negative symptoms than Risperdal. Vraylar did not affect positive symptoms, depression, or EPS, but improved social functioning compared with Risperdal. In combination with medications, cognitive behavioral therapy, social skills training, and learning and using coping skills to address the daily challenges of schizophrenia helps with activities of daily living, such as obtaining a job and increase social skills.